disease with internal fixation. Scott?
Thanks, Jesse. Just got back from shoveling the backyard. Well, that was a very, very nice discussion that Matt had leading into fixation, describing the different approaches to actually get there. As Matt said, if you can't see it, you can't fix it. So we'll go over some of the fixation options and techniques, just a disclosure slide. Well, first of all, you don't have to fix them. You can treat them in the bag of bones technique, which was more popular in the 1940s and such. And I've actually been humbled a little bit. I've had a few patients who are either infirm or too sick to operate on, who actually did okay, not quite like the picture you see on the right, but that's really just for the infirm patient nowadays. The standard is open reduction internal fixation, and that's what we'll be talking about today. We can talk a little bit about the biomechanics of fixation. There actually was a fair amount of work done on this in the 90s and over the past 5 years, and there were different designs, as you can see on the slide there, of 90-90 Y-type plates and cross screws. And I think one of the things that I've noted is that a lot of these papers or biomechanical studies really depends on the instrumentation set and the company you're using. A lot of different companies make a great parallel plating system, and some seem to make a better 90-90, and I think it's the surgeon's choice to kind of look at those different configurations. And the reality is, if you look at most of these studies, if they're comparing one company's 90-90 to to their own parallel, there are different strengths within a company's own set of devices. So I think actually we can say nowadays that it's ancient history or old data to say that 90-90 is better than parallel or parallel is better than 90-90. You can see several studies that have listed there that tried to look at that very question. But I think you can engineer a plating system to be either poor at 90-90 or great at 90-90, and the same about parallel. So it really depends on that particular system you're using. And having said that, I think you as the surgeon should look at the fracture construct and decide whether that particular fracture pattern fits a 90-90 fixation pattern better. For example, if you're missing some bone in the trochlear region, you may not want to overcompress from a parallel standpoint, in which case you may want to use a 90-90 type configuration. Well, I'll just run through some of the simple guidelines. You can have a BYOP party. You can bend your own plate, and this is becoming less fashionable. Now we have anatomic plates, and we're all a little bit more in a hurry. I would say that this is quite an art, and you actually, when I did this, I would do this on the bones we have in the operating room. And if you go to the OR, having not pre-bent your own flat plates, we see these patients come in needing revision. So if you are going to BYOP, take a cadaver bone that we usually have in most ORs and bend the plates and then flash them. So if you get them close, then you can adjust them when you get in. That technique, I was happy, as you can see the picture on the right there. Some guidelines to follow is you want to maximize distal fragment fixation. That means putting the small joint pieces together first. And then you want to compress that construct to the humeral shafts. And we can kind of, as we say for the proximal part of the humerus, putting the ice cream back on the cone, you kind of want to do the same distally. So do your distal fixation first and then compress it. It's interesting, most of the non-unions that we see tend to be at the supracondylar level, not surprisingly at the intra-articular level. Also, if you're missing bone and you have only point-to-point contact, you can consider shortening the bone, and you can easily shorten the humerus about 2 centimeters without any noticeable effects, something you can't really do in the radius or in the femur for that matter. You want to strive to be able to achieve early range of motion without protection. Now, having said that, if you have a little old lady and you put it together with eggshells and you're happy the way it looks, I cast them. I have a great operation for a stiff elbow, but I don't have a good operation for a fracture that's fallen apart and is now stiff and dislocated. And again, as I mentioned, non-unions usually at the supracondylar level. You want to repair the articular surface, and when you do that, the anterior part of the distal humerus is the most critical to reconstruct. you don't need to worry as much about posterior. And I'll show a case at the end to demonstrate that. And for stability, you need the medial trochlea and either the lateral trochlea or capitellum. If you're missing bone in the middle part of the articular surface, you can use graft to hold it together, but you need to have your capitellum and your medial trochlea at the very least. Otherwise, you have a very difficult problem. Posterior fragments are fixed last, and often I'll use those posterior fragments as graft, actually, quite frankly. And you want to achieve provisional fixation with K-wires or pins, threaded or non-threaded. I don't think it matters that much. So here's what it looks like. You're trying to put it back together, and depending on the plating system you're using, you want to try to keep those pins out of where the plates would probably go, unless it's a system that allows you to pin through the plate, for instance. So you can use a parallel plating technique or 90-90, and again, it's really dealer's choice. But again, you want to, after you get the pins together, reducing the distal articular surface, you want to try and compress that to the shaft. Again, I'll often put some pins just under the articular surface to bring some of the smaller pieces together. Sometimes I'll use 2 or 3 K-wires. I cut them off flush and sometimes burn them. And I'll load them in there before I start putting the plates on. Then put the plates on, and then starting some screw fixation, usually like rotating my tires. I put one plate on provisionally, whatever I think I can get the most accurate construct fixed, and then the other side. But do not put all the screws in at all. You want to alternate back and forth, because otherwise you may find yourself unable to put screws in from one side. So you'll have a construct that looks something like this. You have multiple screws. And I'm a fan of putting multiple screws. I haven't seen anybody, we can talk about this, developing a non-union from perfect or from strong fixation. So there's a screw outside the plate, for instance, there, and then there's room for another screw here if I need it. So I do try and strive for at least 5 screws, depending if it's parallel or if it's 90-90. I can often get six screws in the distal articular surface, but you want to make sure, as my partner Sean Distal describes, is building the arch of the distal articular surface from the medial to the lateral side. We described an approach where we combine an osteotomy and listen at the anchineus, and you can see that here, where we're putting, again, the distal articular surface together with pins, and you can see here we're using clamps to hold the reduction. And in this case, if you look carefully at the center part of the articular surface, we're missing some bone. So in this case, I did not want to use parallel, but did a 90-90. Therefore, I wouldn't compress that articular surface together. And again, while I was doing this case, if I saw no problem and thought a parallel would be better for this particular patient, I would have switched to parallel. I'm not committed to 90-90 or parallel techniques. Just post-operative radiographs. And as Graham mentioned, I tend to use a plate for closure, but I have no hard feelings for that. I think the best technique is whatever you're happy with. We can talk about whether to do an osteotomy, whether you need to do a chevron or a transverse. I used to do a chevron, and probably about 5-6 years ago started just doing a transverse, where I use a saw for 1/3, an osteotome for the middle third. I break the anterior third, and that's what I put back at the end. Post-operatively, I put in a Statue of Liberty position, elevated up, and for 24 hours. I don't use CPM as much in the fractures as I used to. I worry about taking the fracture apart, and most of the patients that have secure fixation, I just have them start moving as soon as possible. Results, we can talk just briefly about. Pretty much all the results are about the usual 75% good to excellent results. Another study from 93, 75 good to excellent results. On the neuropathy, we can talk about. I tell all my patients now that have a distal humerus fracture that they will wake up with their small finger numb, and if they have any questions about that, I usually address that. Usually that improves, but there's at least a 10% rate, at least in my practice, of problems related to ulnar nerve, with in some cases prolonged numbness, but not usually motor problems. We looked at parallel plate fixation and really showed no difference between using pre-contoured parallel plates versus other techniques that are out there. So nothing earth-shattering there. Just a word of some techniques that don't work. You don't want to treat an adult like a child. There's a fracture that came in to see one of my partners, was fixed like this and ended up looking like that. So that obviously needs to be revised. Someone sent me this picture and said, how's this look? And I said, don't have the patient exhale. If you look carefully, there's only one screw holding the distal articular surface piece to the shaft itself. So it's a very interesting technique of fixation. You can see that screw right there. I'll just finish with this one case, just kind of demonstrating some of the things we spoke about, just to walk through it. 18-year-old MVA, open fracture posteriorly. Here's the X-ray, as you can see. So we have a shaft fracture, olecranon fracture, and distal humerus fracture. That night, the trauma team put an X-fix on, washed it out, put beads in, and we can see the CT here, 3D, showing comminution in the shaft. And when you approach this, you obviously want to fix the easiest fracture first, so you'll fix the shaft fracture and work your way up. And then the last thing you want to do, of course, is put your olecranon fracture back together. So you can see the traumatic portion in the middle there with the arrow, and then our surgical approach that we started there. Lots of little arrows on the small fragments that need to go back together. But again, just as I described, you start getting to work on that distal articular surface, and you can't see all the pins, but there are several pins in that distal articular surface buried, holding that together. You can see we're going to get great radio reception here with all the pins that we have holding that in place. We've fixed our shaft fracture, and we've applied a plate on the medial side there. And in this instance, I thought, again, that a 90-90 fixation might be better. You can see some sutures there that are trying to hold on kibbles and a comminuted capitellum in that instance. And we're missing, we don't have the posterior part of the trochlea there, as you can see. And there's still a hole going right through to the anterior surface. So we've restored the arch, but for greater stability, you see the arrow there, I took the posterior part of the trochlea and gently tap that in to fill that in. So we've got support now for the distal articular surface. Then we put that back together, and then of course the patient comes back at post-op day number 5. Maybe we can take a vote. Anybody think this is just going to heal up fine, just dandy? Probably not. But anyway, that was post-op day number 5. 4 months follow-up, healed up fine. But we see an exposed plate. We can perhaps talk about this a little bit, but I've seen patients get sent to us looking like this. Oh my gosh, you need to do something. And then several of my own patients come back, particularly after open trauma or severe trauma to the soft tissues. I used to try and cover it up by taking them to the OR and raising flaps and covering it, but I found it never heals until you get the metal out. So nowadays, I just tell them just keep an eye on it. As long as it looks benign, like you see in the picture, they don't need to put Dakins on it. Just keep an eye on it, keep it clean. And in 4 months, I'll take the plate out, as you can see here. And unfortunately, I didn't have a picture of it healed, but she healed up fine. We did that. I think that was just a few months ago. Well, thank you again, and happy to take any questions.
Okay, thanks, Scott. There are a few people wondering about this shortening. It seems like it's a tremendous amount of shortening near the olecranon fossa. Do you lose extension when you are doing that?
I think it's possible if you shorten over 2 centimeters to actually lose strength of flexion and extension. I haven't had to do that, and I might add, very rarely nowadays do I consider shortening. Most of the time, I'm able to get some interdigitation, but I would be careful about shortening over 2 centimeters, because I think we did a study in the biomechanics lab here. Mind you, it was in cadavers, but showed that there didn't seem to be much difference at 2 centimeters. And once you got over that, you started seeing some changes.
Scott, everybody who responded said that wound wouldn't heal.
Excellent.
Okay. And then the question that's come up when I look at your cases and I look at all these medial plating is whether or not you're risking a higher problem of avascular necrosis of some of these fragments. It seems like there's an awful lot of the blood supply being taken away by placing the plates so parallel.
I think that's a good question. Anecdotally, I haven't seen that. I'm not aware of anybody that's actually studied that. I would use common sense or suggest common sense, orthopedic common sense, that is, that the more stripping you do of the fragments, the less chance that they may go into a non-union. Actually, I had a case I just put together for another conference I'm going to that I think demonstrates either AVN or a subtle infection where the articular surface indeed did go on to degeneration and loss of cartilage. So I think you can definitely see that. I think it's, in my practice, or I think it's actually rarer for everybody than I would expect. I would expect to see it more commonly with these small pieces like that case I just showed of non-union, but it tends to be more the supracondylar level.
Okay, we're going to move to the very difficult fractures with